Okay. All right, so hemodynamics is, like I said, blood circulation. So if you understand blood flow through the heart, then you're going to understand hemodynamics a lot better. Because basically, if you look at blood flow through the heart, and you see where something's blocked or not working, you're going to understand if it goes forward or backward or things like that. So these are just things you need to understand related to hemodynamics that we'll get into. So basically, as I said, all hemodynamics refers to is the blood circulation. How that blood circulates through that heart and lungs and around the body is what hemodynamics is all about. The goal is that this heart pumps and oxygenates the body, right? So that's the whole goal. So in order for us to have good circulation, all of these three things need to be there, right? We need to have a heart that works, right? We need to have a good pump. Not only do we need to have a good pump, but my lungs have to be okay, right? And if I have a lot of things going on with my lungs, am I going to oxygenate as well? If I have pulmonary fibrosis, if I have pneumonia, if I have COPD, if I have cystic fibrosis, right? If I have acute respiratory failure, if I have ARDS, if I have all kinds of these lung problems, I'm not going to be able to oxygenate. The other thing, your hemoglobin has to be adequate enough, because where's your oxygen carried? On the red blood cell. You know, they used to always transfuse somebody at 8. Now they don't transfuse till 7. The only time they transfuse any sooner than that is if the patient is what? Symptomatic. I'm right back to telling you, look at your patients, okay? Everybody's going to respond differently to what's going on, okay, in the body. So all those things have to be working correctly for you to function like you are right now. Okay, if there's a problem in any of these three, then it's going to affect the hemodynamics, and all hemodynamics means is that blood going around your body, okay, throughout your body. So basically, it's basically the balance between blood and oxygen, okay? That's basically what it is, the balance between blood and oxygen. So basically, there's different ways that we can check out what's going on internally. And we'll get into these a little bit more. One is non-invasive. The first one is non-invasive, and this is called ICG monitoring. And basically what this does is it's looking at the mechanical function of the heart. It's not looking at the electrical function of the heart, but the mechanical function of the heart and the ability of that heart to deliver blood to your body. And I have a picture later on that shows you these electrodes that they put on the patient, and they hook them up to a machine. And when they hook them up to the machine, then they can figure out whether or not your heart is pumping adequately. So that's non-invasive. So they don't have to, you know, do anything invasive. And I have a picture of that later on in your slides that I'll show you. But for now, I just wanted to give you a global way we can monitor it. Another is called a flow track. A flow track basically attaches to what we call an arterial line. And an arterial line is something that they put in the artery, right? Usually the radial artery. And the purpose of an arterial line is so that I can do continuous blood pressure monitoring on my patient, and also to get lab draws, okay? So this flow track hooks right up to that art line, and then the flow track monitor will give you these pressures. What's the CVP? What's the PAOP? Whatever. I think we have some in trauma at St. Mary's, but not, I haven't seen any in 6I, okay? So basically, the other thing that we look at is what's going on with this patient, right? What's my assessment in this patient so that I know they're getting oxygenated and perfused, right? So you have to think about, okay, all right, yep, they're alert and they're oriented right, their color is good, their heart rate's normal, their blood pressure's normal, their O2 sat's normal, their blood gases look good. Do you understand what I'm saying? I've got good cap refill. I could go on forever. So your assessment too has to be a part of this. Invasive is something called a pulmonary artery catheter or a Swan-Ganz catheter. So they call it a PA line for pulmonary artery catheter, or they call it a Swan-Ganz line. And I do have one that I'll open up when you go on break, and then you can look at it, what a swan looks like. So anyway, and I'll show you kind of a little picture too of what a Swan-Ganz is. So a Swan-Ganz line is invasive. They don't use these often anymore because of the high risk of infection. The other problem, is that when they put them in, okay, you can get a pneumothorax because they got to put them in with a needle. All right, they got to get in under that skin somehow. And so they don't use them very often anymore. All right, don't see these as much as we used to see a long time ago. All right, more common maybe on your post-cabbage patient, but most of your patients in ICU used to have these. They don't have them anymore. Hence, the more important assessment skills are even more critical because we don't use them that much. Okay, so it's inserted by a physician at the bedside. And as I said, it's usually inserted into the subclavian, okay, and then they pass it into the right side of the heart, right ventricle, and into that pulmonary artery. And it just kind of floats there in that pulmonary artery until we blow up what we call a balloon that I'll talk about in a minute. And so it just kind of floats there. The problem is when they're putting them in, I'm irritating my heart, so I can have arrhythmias when we put these in. So again, you need to assess your patients constantly, even when we're doing a procedure like this. So this is going to give them invaluable information about what's going on in relationship to hemodynamics. So what we want to try to do is we want to make sure we're perfusing the body. That's what we're trying to figure out. Are we perfusing that body? Is that heart able to pump good enough? Are my lungs working good enough that I'm doing that oxygen exchange right at the alveoli? Am I able to get enough blood out into the body, correct? So the goal is to actually make sure we have adequate perfusion. So what will happen is that if these people are on medication to help with some problems like too much volume, right? Or maybe too much afterload, the afterload's too high, they can be put on medications. And when they're put on those medications, what they do in the ICU units is they do what they call titrate. All right, so what they do is they look at the patient, look at the numbers, see what's going on, and they adjust that medication either higher or lower depending on patient presentation and numbers on a monitor. You will not titrate medications, okay? You're not going to be titrating medications. I do have people in ICU, but you shouldn't be titrating those medications. So basically, as I said, the goal is right here. If these aren't working, I have a problem with my hemodynamics. Okay, so I got to have a good pump, I got to have good lungs, and I have to have a normal hemoglobin or close to normal. All right. So some of the components that you need to understand before we even can get into hemodynamics are some of these terms. Cardiac output. This is not new to you. Cardiac output should not be new to you. Cardiac output basically is the amount of blood that the heart pumps in 1 minute. Okay, so cardiac output is how much blood the heart is pumping out to the body in 1 minute. Normal is 4 to 8 liters. Okay. Why do I care about cardiac output? Well, I care about cardiac output because I want to make sure that I'm perfusing the body and oxygenating the body. And decreased cardiac output, less oxygenation, less perfusion, okay? Cardiac index, this is more specific because it uses the body surface area of the person, okay? So everybody's got a different body surface area, and so the cardiac index is a much more adequate or accurate way of trying to determine cardiac output, all right? And normal is 2.5 to 4 liters per minute. So cardiac index is something else that they look at, and they measure it using body surface area. So when your patients are admitted, they always have height, weight, body surface, up there. So that's what they would do the physicians would figure out to make sure that's where we are with cardiac index. Stroke volume is per heartbeat, right? Stroke volume is how much is put out each time that heart beats. Now, books tell you different things. Some say a good stroke volume, is 60. Some say 70. So I just put stroke volume. You want 70 to 100 or 60 to 100 cc's each time that heart contracts. So that's what I need, minimum 60 for me to perfuse the body, okay? So that's what stroke volume is. So those are things you've seen before, correct? Nothing brand new. All right, systemic vascular resistance and pulmonary vascular resistance. Systemic is out here. Systemic is out here in my body. Systemic vascular resistance equals afterload, okay? It's the load after the pump, right? So remember I had that gentleman's little IV bag, and then I had the IV pump being the heart, and then I had the tubing. That is systemic vascular resistance. It's that tubing. It's the load after the pump. It's how hard that heart has to work to pump that blood out into systemic circulation, okay? That's systemic vascular resistance. So we can give medications, the technical term, they use them afterload reducers, but they're medicines you've heard of. We can give medications that open that up, right? We talked about some of them yesterday. So we can give medicines to open up that tubing to make it easier for that heart to pump, right? So think about this. You have somebody who had an MI, and part of that left ventricle has been affected, right? I don't have as much contractility. So that heart can't get that volume out. Or what it does is it speeds up, right? It says, oh, I can help you out because I'm going to beat faster, but faster isn't better because I'm not filling. I'm decreasing my cardiac output. I'm just decreasing my stroke volume. The other thing that happens over time is they can go into congestive heart failure, right? Because the heart says bigger is better, so I'm going to get bigger. But that hypertrophied muscle isn't good contractile tissue. So you have to think about those things when you're thinking about somebody that has heart problems. So systemic vascular resistance out here. Systemic circulation, okay? It's the load after the pump, hence the term afterload. Does that make sense? Okay. The other one is pulmonary vascular resistance. So where do you think pulmonary vascular resistance will be? In the lungs, okay? So we're looking at pulmonary vascular resistance. Now it says afterload of the right side of the heart, because what comes after the right side of the heart? Where does the blood go? To the lungs. So it's the load after the heart, the right side of the heart, right? Because when you look at blood circulation, right? Venous, right side, pulmonary artery, okay? So we're looking at the pressures within that pulmonary artery, okay? So that's what pulmonary vascular resistance is. So think about somebody that has pulmonary fibrosis. What do you think that pulmonary vascular resistance is going to be? It's going to be higher, right? What's the right side of that heart have to do? Oh my God, I got to work harder. I'm working as hard as I can. Oh, now bigger is better, so now I have right-sided heart failure. Okay? So you see what I'm saying? All you have to do is think, how does that blood go through this heart and into the body? And you understand hemodynamics. So if you don't understand blood flow through the heart, my suggestion is to draw a picture or print a picture off and make sure you understand it, okay? Because that's critical to understanding hemodynamics, okay? More terminology, we already know this, right? We already know what contractility is, right? It's when that heart, right, contracts, correct? To push volume out into the body, okay? And then we have ejection fraction, and that is given in a percentage, and that is the percentage of blood that's pumped out of those ventricles each time that heart contracts, right? That's ejection fraction. So what's a normal ejection fraction? Yeah, it depends on where you go. Some say 55 to 60, 65% is good, a good ejection fraction. So basically you need a good ejection fraction, right, to get perfusion to the body. So that's just more terminology. Okay, it's missing. My link is missing. I'll find the link. That's the IV pump. I'll find that link. I don't know why it's not there. Do you have it on your sheet? Isn't that weird? That's spooky. I'll find it on break and I'll have to come back. Okay, so preload. Want to talk a little bit about preload. What did we say preload was? Volume. Okay, so when you're talking about preload, it's the volume before, right? Preload before. So preload is volume. And what did we say afterload was? Okay, afterload equals resistance, right? Now you can have systemic vascular resistance or pulmonary vascular resistance, correct? We just mentioned that. So remember again, when with this guy's little IV pump, this is the bag, right? This is the pump. They look the same, but it's okay. Whoops. This is the pump, and this is the tubing. So this is preload. This is afterload systemic, okay? Preload and afterload. So preload is volume. So it is the volume, okay, the venous blood that's coming back to the heart, okay? So it's that volume that is coming back to the heart. Does that make sense? Because it's volume. So technically preload is that we don't measure it in volumes, unfortunately. We measure it in pressures, okay? But preload is volume. It's the amount of blood in those ventricles after they fill. So it's the amount of blood in those ventricles after they fill. All right? That's preload. It's volume coming to the heart. So how much volume, right? How much volume is in these ventricles after diastole? Okay? Does that make sense? Preload is volume, because I have to have volume, right? And the reason they call it end diastolic volume, why do they call this end diastolic volume preload? It's after diastole, it's after filling, right? So it's after diastole. Diastole is filling. So all it's saying is, okay, this is the volume in these ventricles after they fill. That's preload. We okay with that? So preload is the amount of volume in those ventricles after they fill. But we never measure it in volume, of course. They have to talk that way, but we measure them in pressures, okay? So you can have right ventricle end diastolic pressure, right? Right ventricle at the end of diastole, right? So right ventricle end diastolic pressure. Volume is measured in as pressures, and we'll get to that. So do you understand what that means? That's how much volume is in this ventricle, the right ventricle, after it fills, okay? You can have left ventricle and diastolic pressure. So that's telling me, right, how much volume is in that left ventricle at the end of diastole. So these terms should not be unfamiliar to you, right? I mean, it's just right ventricle at the end of diastole, how much fluid's in that right ventricle. Does that make sense? Okay, at the end of diastole, how much fluid is in that left ventricle? But it's measured in pressure, okay? Does that, it's like central venous pressure, CVP, it measures it in a pressure. So I'm looking at preload by using the CVP, or central venous pressure. Okay, so preload, I'm looking at something called central, oh, that's a good one, throw that one in the trash. Something called central venous pressure, okay? Because the V is venous, right? And it's venous blood that comes to the right side of the heart, correct? It's venous blood. So that's why CVP, see that means central venous pressure. So it's the pressure in the venous system that's coming back to the heart, okay? So CVP, venous pressure, okay? CVP, all right, normal CVP is what? 2 to 8. 2 to 8. Now this is kind of a little low, this number, but the more they're on the lower end, the less what they have. Fluid, right? Because all this is telling me is if they have too much fluid, what are they? Hypervolemic. If they don't have enough fluid, what are they? Hypovolemic. So that's all CVP is telling me, is fluid volume, okay? That's all it's telling me. So if the closer I am to 2, the more dry I am. the closer I am to 8, the more fluid I have. Now, I will tell you, depending on the patient, sometimes they like to maintain the CVP a little bit higher, okay? But I'm not going to get into that, okay? If you're in ICU, we'll talk about that. If you're not, it's okay. So central venous pressure, remember it says venous, okay? Venous. Since we say it's deoxygenated, I'll make it blue. Venous, okay? So central venous pressure is how we measure preload, okay? Because we measure it in a pressure. So this is how we measure preload, okay? Does that make sense? So preload is volume. It's the venous return to the heart. It's the amount of volume that is coming back to the heart and how much is in those ventricles after they fill. Hence, right ventricular end diastolic pressure. Okay, left ventricular end diastolic pressure. So we're measuring pressures, right, versus volume. But volume equals pressure, right? The greater the volume, the greater the pressure. All right, does that make sense? So the amount, this is going to be dependent upon how much blood is coming back to that heart. So you think about somebody who has internal bleeding, right? Am I going to have as much venous return to the heart if I have a massive bleed? No. Well, that might be the patient that they want this CVP at 12, because I just want to make sure they have enough fluid. Or a gunshot wound victim, I want to make sure they have enough fluid. All right, do you see what I'm saying? So they can manipulate the patient's fluids that they're getting by knowing this CVP. Okay? Now, we don't do this on the floors, obviously. We do this in the units, but, you know. So my preload can be affected by all kinds of things, right? So if the patient's on a medicine that causes systemic vasodilation, what's going to happen to my preload? It's going to decrease. If I give them vasopressors where I'm squeezing, do you see what I'm saying? So all it is volume. Am I hypervolemic or hypovolemic? Okay? If I'm hypervolemic, I don't want to give you any more fluids, right? The bag is full, like the guy said. If the bag is full, why do you want to keep giving them fluids? Where's it going to go? Backwards. It's going to stress that right side of the heart. It doesn't have anywhere to go. So if the bag is full, why fill it? Why keep trying to fill it? That's why you have to know this stuff, okay? So I don't want to keep filling the bag. Okay, does that make sense? But if the bag is empty, I gotta give them some fluids. Because if my CVP is low, I don't have enough cardiac output. So guess what I'm not perfusing? My body, right? Does that make sense? You understand the concept of preload? So preload is volume, okay? Preload is volume. Now, these are some of the things that can affect preload, okay? And obviously increased fluid volume, right? And even venous vasoconstriction can increase preload, because what you have to understand is that venous vasoconstriction isn't like this. It's not 100%. All it's doing, what happens to your blood vessels when you walk? Squeeze volume forward, squeeze volume forward, squeeze volume forward, right? That's what this does, okay? So veins hold about 60 to 70% of the blood in your body. So most of the blood in your body is venous. That's a lot of blood. And so the veins hold the majority of the blood. Therefore, when you initially constrict them, it's going to push all the blood forward that's in those veins, right? And then eventually you can give them something that just causes enough constriction to try to increase preload. But it's not 100%. So that's how it increases preload, because here's the volume, I'm pushing it forward. Here's the volume, I'm going to contract, push it forward. Does that make sense? That's what it's talking about. It's not saying I'm clamping at 100%. Because if I'm clamping at 100%, you might as well not be here, because you won't be here. All right? It's just enough, you know, like a TED hose, you know, you squeeze it, or an SCD, squeeze it, push it forward, squeeze it, push it forward. Isn't that what TED hose and SCDs are kind of trying to think about conceptually? That's what that's talking about. So it's kind of increasing that venous volume back to the heart so it doesn't sit there. So it's kind of pushing it forward. Decrease makes sense. Not enough volume, and now my pipes are bigger. So if your pipes are bigger, right, and they're not full, I'm not getting as much volume back to the right side of the heart. So that's preload. Measure it. What did I say? Central venous pressure, right? Central venous pressure is how we measure it. Normal central venous pressure is 2 to 8, okay? So the central venous pressure is measuring that blood volume or that venous return to the heart. That's what central venous pressure is measuring, okay? The other thing that we have to talk about, so that's right side of the heart, okay? So this is right side, correct? CVP is right side. So it's telling me what's happening with the volume on this side of the heart, okay? But how do I know what's happening with the volume on that side of the heart? Okay, I have a catheter in, but now what I'm going to do is I'm going to be measuring something called my pulmonary artery occlusion pressure. So your pulmonary artery occlusion pressure, and I'll explain that in a minute, pulmonary capillary wedge pressure, okay, looks at left side preload, okay? Left side preload. So when you look at left side preload, a student drew this. So I'm going to show you a couple of things. Duck cam? Ooh, that's nasty. Okay. So this is how we measure left side preload. Okay. We use it like he said with a pulmonary artery catheter. Okay. We measure it with a pulmonary artery catheter, all right, that you mentioned. Come on, come bigger. So there is this catheter in this kit, okay? There's this catheter in this kit, and what happens with this catheter, as I said, the doctor has to use a needle, go into the subclavian. Then what happens is here's the swan line, and then this is the swan line right here. So it goes into the subclavian, right ventricle, right? CVP, or right atrium, I'm sorry. See, now you corrected me again. I'm just going to sit down. Okay. So, my mind's over here already. So, right atrium to the right ventricle, and then this, just forget that this is blown up, okay? So, it goes in here and it just floats back and forth. As the blood, it just floats back and forth. So, what's happening is I can measure CVP here. But how do I measure that volume over here is something called pulmonary artery occlusion or capillary wedge pressure. So when you're talking about your lungs, when you have your lungs, and you know I can draw, so just be ready. I'm not even going to try because you can just laugh. So you have your pulmonary artery, right? And it goes to your lungs. These are your lungs, see? And in between here, we have capillaries. Okay, so you have your pulmonary artery, but these are capillaries, okay? And then those capillaries end up over here becoming your pulmonary veins, okay? So when I'm talking about capillary wedge pressure, that's what I'm talking about. So what's going to happen is this balloon is going to be floating around in there, right? And then the doctor says, well, I want to know what's happening on that left side of the heart. I need to know how much volume is in that ventricle. I got to figure that out. So what they do is as this is floating back and forth, they blow up a balloon. Okay? When they blow up that balloon, okay, what that balloon does in this vessel, when they blow it up, they call that a wedge pressure because it's wedged against the vessels in the capillary. So they're blowing it up in here, okay? They're blowing it up in the capillaries. That's why it's called capillary wedge pressure, okay? And when it blows it up, on this end right here is a transducer, okay? That transducer is reading the pressures on the left side of the heart. It can't read behind the balloon. It can't read behind the balloon. because the balloon is blocking it. It reads what's forward. What's forward? What's here? What's this?
Sure.
My left what? Atrium. So technically we're measuring pressures, okay? So technically we're measuring left atrial pressure is what it measures. But it doesn't matter. You're measuring pressure. So that's how you get left ventricular, all right? Left ventricular preload is measured with this pulmonary artery catheter, okay? So basically, here's another little picture, okay? So here's another little picture, all right? And I don't care about all this. This is just everything you can hook up to. So, you know, you can look at right atrial port, the distal pulmonary artery. So anyway, this is floating in, and it just floats back and forth in this pulmonary artery. And then here's your capillaries, okay? So hence pulmonary capillary wedge pressure. So they say, guess what I want? I want to know now what's going on the left side of the heart. So what they do is they blow up this balloon. And they blow up the balloon and it wedges in those capillaries, okay? And then right on this side, right here is the transducer. The transducer is measuring forward. So it's measuring forward. So it's measuring the pressures in the left side of the heart, okay? So that's how we measure left ventricular preload, all right, is through this pulmonary artery catheter. So your pulmonary artery occlusion, because I'm occluding that pulmonary artery, right? Or pulmonary capillary wedge pressure, because it's blowing up there, is telling me left side preload. Does that make sense? Some of you are like, I don't know. It's just blood circulation. That's it. So all this is doing is telling me what's going on the left side of the heart. So this is coming in here to the right atrium, to the right ventricle, and it's hanging around in here, okay? Oh, pulmonary artery. But it's hanging around in the pulmonary artery. And then the doctor says, I want to know what's going on over here. Well, the only way I can do that is to blow up that balloon so it wedges, and then the transducer is measuring what's here. Okay, it's measuring the pressure in that, technically in the left atrium is what it's measuring. Because if my ventricle is full, my left atrial pressure will be good. So it's measuring the pressures on the left side of the heart, which is your preload. Okay?
So the balloon stays in the pulmonary artery? But
No, no ma'am.
Goes into the atrium?
No, the transducer is at the end of that tubing.
Okay, so the transducer
Is part of that
goes
tubing.
into the left atrium?
No, it can just measure the pressure.
It doesn't go.
No, does not have to go into the left atrium. It can measure the pressure.
So where does it say that?
It just it's part of the tubing. But I don't leave it blown up, because if I leave it blown up,
You don't leave it blown up, but when you blow it up to get your pressure, it's in the pulmonary
it's
artery.
right here. It's right here. The transducer is
Left side of the heart.
right. Right. Pulmonary artery pressure. You blow it up. Okay? This transducer is just part of the tubing, like a Foley catheter. You know how the Foley catheter has those little holes in the end? Well, just figure that part of it has a transducer in it. Okay? And so that's able to measure those pressures. You can never do these because I can rupture that blood vessel. These can't be blown up for more than like 10 seconds. So that's why students can never do this, and you have to be trained to do this. So all I do is this balloon is always deflated. It's never inflated except to figure out what's going on my left side of the heart. So if I want to find out if this patient's having really bad heart failure on the left side of the heart, I want to know my PaOP, because that's going to give me volume on the left side of the heart. Right side is CVP, volume. Left side is PaOP, or pulmonary capillary wedge pressure, okay? So basically then I deflate the balloon. The transducer is part of that tubing, okay? It's part of that. And then I just deflate the balloon, and the tubing just kind of goes back and forth until the doctor says I want another wedge pressure. Then they blow up that balloon again, and then they get another wedge pressure, okay? Does that make sense?
So to clarify, it's really measuring the pressure inside of the pulmonary artery distal of the balloon, which is equivalent to the...
No, it's not measuring the pressure in the pulmonary artery. That's another pressure. I can do a pulmonary artery pressure. We haven't gotten to that yet. Okay. Well, it floats around in the pulmonary artery, yep. And then when I want to what happens then is these are the capillaries. Okay? So if I want a pulmonary artery wedge pressure, I wedge it in the pulmonary artery. If I want a pulmonary capillary wedge pressure, I want to know the left side of the heart, it's going to wedge in the capillaries. Okay? So I can do a pulmonary artery pressure too. So I can do a central venous pressure, a pulmonary artery pressure, and a pulmonary artery occlusion pressure. There's only 3 pressures. CVP is right side, PAP is the pulmonary artery, PAOP is telling me what's going on the left side of the heart. That's it. 3 pressures. Okay? So this is really looking at, because what's next after the lung? The heart. So that transducer is reading forward. So it's reading what's going on here. It can't read backwards. Okay? And if you notice, and I don't even get into this, there's different ports on this so that they can read different pressures because of the different ports on here. But that's just too much. I just want you to understand CVP is volume. It's venous return to the heart, right? It's right-sided preload. Preload. How much volume is in the ventricles after they fill? Okay? Left side. How do I figure out left side? I got to use my pulmonary artery catheter or my Swan-Ganz catheter. Okay? It's technically measuring the pressure in the left atrium. But that's reflective of what's going on here, right? The higher this pressure, the more volume in here. The lower this pressure, the less volume in here, right? Because if I have too much volume in here, where's it going to go? It's going to backflow. Normal. It's just normal blood circulation. It's going to backflow. So if I have too much volume, it's going to backflow to the left atrium, hence my pressures are going to be higher. If I don't have enough volume, my pressures are going to be lower. It's just normal blood circulation. Okay? It just think in your head, blood flow through the heart. Okay? So we okay so far? CVP right side, PAP we haven't gotten to is lung, PAOP is left side. Okay? I mean, you're going to need to know it for the test, so you better understand it. I'm going to strongly suggest this, and this is what I tell students. Go home and draw a picture of the heart. Make sure you understand blood flow through the heart first. Then look at these concepts of preload, okay, afterload, etc., because that's the best way to understand it. Normal numbers for this is 4 to 12. Okay, because we measure pressure. Normal is 4 to 12. Okay, so that's what we're trying to measure. Normal pressure is 4 to 12. Okay, does that make sense? So then if the pressure is low, it's telling me what? Decreased volume. If the pressure is high, it's telling me I have a lot more volume. So maybe that left lung isn't working like it should, right? Or the left heart, I should say, not lung, is not working like it should. Does that make sense? So, right side is looking at body, right? So the CVP is, you're going to see things. If the CVP is high, you're going to see, signs and symptoms like right-sided because it backflows, right? Right-sided heart failure. Left-sided heart failure, you're going to see more respiratory systems, right? Respiratory symptoms, I should say, okay? So, you got it? You got it? You got it? I want to try to see if this is something else somebody gave me. Okay. All right, so you sort of think you have that? You sort of? Right? CVP is right preload, PAOP is left preload, PAP is lung. Okay?
I think what kind of confused me at first, I just wanted to say it out loud. The PAOP and the C,
They're the same thing.
and the SWAN, it's all,
The PAOP, PC, WP is the same terminology. Sometimes they call it pulmonary capillary wedge pressure. Sometimes they call it pulmonary artery occlusion pressure. It's measured with the SWAN. Okay? You have to have the balloon blown up to figure out what's going on that left side of the heart. Okay? If that balloon's not blown up, you don't know what's going on that left side of the heart. Okay? All right, so CVP is volume. Now, I'm not going to read through this slide. But CVP is volume. It's right-sided heart, right? It's what's going on the right side of the heart. So these are all the kinds of things that can increase that value. And this isn't totally inclusive, okay? I just kind of run out of space. So these are things that can increase my CVP, right? And these are things that can decrease my CVP. Now you're going to learn with sepsis, how that works is with sepsis, you get vasodilation of the blood vessels. Okay, they get bigger. Hence, they lower the volume because the pipes aren't full. Okay, do those make sense? You've already learned about regurg and insufficiency and stenosis of valves, so you should understand that, correct? All right. Do those make sense? Yes, no, maybe so. So anything that affects volume, right? Right? And it could be disease processes, it could be medications. Okay. We good with that? All right. And of course, this is not totally inclusive, right? But if CVP is volume, that's what I want to assess, right? I want to assess if my patient has fluid volume overload. And I don't have everything here. I only have a few things here, just for, because that list could go on forever. Complications of a CVP, basically one of the problems is, as I already said, a pneumothorax, right? Because I'm putting a needle in there to be able to get that catheter in there. I also mentioned dysrhythmias because you're kind of tickling that heart and irritating that heart as we put that through. So the person can actually have arrhythmias. Hemorrhage, right? Sticking a needle in a blood vessel, infection, because I have, right? I broke the skin, so now I have infection. Thromboembolic, so you can now get blood clots. Clots love to stick on things, right? They love to stick on the end of catheters and on things. So you can end up having blood clots, and you can also get air in there and get an air embolism. So those are some things you have to worry about. A lot of complications, hence they don't use them very much anymore, okay? All right, afterload is resistance, right? Afterload is the amount of resistance against which that left ventricle has to pump, right? Afterload is the tubing. It's after the pump, right? Afterload, after the pump, okay? Now think about it, it's primarily influenced by fluid volume. But what about people that have really thick blood? The heart has to work harder to push that blood around too, right? So there's some diseases where the viscosity of the blood is a little bit thicker, so it makes it have to push a little bit harder, okay? The greater that resistance, the more that heart has to work, okay? Right? So the narrower this is, the harder the heart has to pump. So if it's a garden hose, it's good. If it's a cigarette stirrer, it's bad. Because think how small that diameter is. So then that heart has to work that much harder, okay? Does that make sense? Right? We good with that? Thank you. All right. So the other thing is, remember I used the word afterload reducers. We're going to talk about these meds a little bit more later, but just understand all these meds are vasodilators. That's why you may hear the term afterload reducers, because what it's doing is it's making this tubing bigger. So I'm vasodilating to decrease how hard that left ventricle has to work to push blood out into the body. So they call them afterload reducers. So you may hear the term afterload reducers, okay? So that's all that means, okay? What causes an increase in afterload? Well, right? The smaller this is, the harder the heart has to work. So when we get that, because remember this is arterial side, right? We're on the left side of the heart. This is arterial side now. So what the smaller these are, the harder we have to work. Hypertension. What do you think happens with hypertension? Boom, right? Narrower blood vessels, heart has to work harder. Increased pressure within that arterial system. So a lot of your blood pressure meds, right, are going to have some effect on this afterload. Okay? So afterload doesn't always have to be a term used only in critical care patients. Does that make sense? So afterload, anything that causes constriction of the arterial system, which is left side, can increase that afterload. Okay? Decrease afterload, basically, with decreased afterload, you have things are less resistance, right? And arterial vasodilation. So that makes sense. Okay? There's pulmonary artery occlusion pressure now. Now we're over here. Okay? Now we're to the left side of the heart. So we're measuring pulmonary artery occlusion or pulmonary capillary wedge pressure. So what we're looking at is what's going on that left side of the heart. How much fluid is in that left ventricle after it fills? That's what we're looking at. Okay? We're going to talk about cardiomyopathies today, right? Dilated is a big floppy heart. It's like a CHF patient, basically. Okay, hypertrophic is you have a smaller ventricle. You don't have as much volume going out. Restrictive is those people don't live very long. Okay, your valves. Why do I have these valves here? Where are they? Where's the mitral valve? Between the left atrium and the left ventricle. Where's the aortic valve? Thank you. From the left ventricle out to the body. That's why they're on this side. Okay? That's why they affect preload on that side. We already talked about tamponade, and then here's reasons for, right? So they're hypovolemic. I gave them a vasodilator, or I'm going into sepsis, and my pipes are getting bigger. That will reduce how much volume I have for that left ventricle, right? Does that make sense? Think of it as volume. That's all we're talking about is volume. So since left side, when you look at blood flow, if I have a problem with my left side of the heart, where does it back up? Into the lungs. Now, it can affect the right over time, correct? What I'm looking at is anything related to respiratory. I don't have everything on there. I'm not going into cap refill, and I'm not doing that. You're past that stage. You should know that stuff already. So I'm not going in. So this is just a little guide that's just, again, showing you or putting together what's preload, what's afterload, okay? What's preload, what's afterload. So we already talked about that, okay? Last one we want to talk about is pulmonary artery pressure. See, and so this is a pulmonary artery catheter. This one doesn't have any needles on it, but you see this little balloon right here? Okay, right here at the end of that is where that transducer is. So when this gets blown up in that blood vessel and those capillaries, this little transducer is measuring left side of the heart. So this is just showing you that little balloon there, but this is actually what one looks like. You don't have to worry about all these ports and stuff like that. That's just too much. So now we've got CVP, right side of the heart, PAOP, left side of the heart. Now we want to look at what's going on in the lung itself. So now we have PAP, pulmonary artery pressure, okay? So now we have PAP, right? So this is where? Lungs, okay? Correct? CVP, right side of the heart, preload. PAOP, left side of the heart, preload. PAP, lung, okay? Pulmonary artery. Okay, so when you're talking about pulmonary artery pressure, basically this also is measured with the balloon inflated in the pulmonary artery, okay? And when you're looking at a pulmonary artery pressure, they actually measure a systolic pressure and they measure a diastolic pressure. And you have those values in your module. But a normal systolic is about 15 to 25. And a normal diastolic is about 8 to 15. So the higher that systolic, the higher the pressure in those arteries. Okay, so it's looking at the pressure, so it's looking at the resistance in those lungs. What's going on that's causing me to have a lot more resistance in my lungs than what I want to have? Okay, so basically pulmonary hypertension, pulmonary fibrosis, Pulmonary embolism. Should have thought of that one, right? Pulmonary embolism. These are all things that affect that lung, okay, that are going to increase that pressure. Again, these are going to decrease volume. If I decrease volume, volume is measured in pressure. So if I decrease volume, I'm decreasing the pressure, okay? So these are all things that increase that volume or pressure, okay, in the lung. And then the other ones, again, are things that decrease that pressure, okay? You're going to practice this in a little bit, so that's why I know you need a break, but I wanted to get through it, and then you can come back and practice. I'll lose you if I leave you. So SVO2 is something else they measure. Basically, this, of course, can be measured through the pulmonary artery catheter also, and this is venous. So this is basically what we call central venous oxygenation. And what it's looking at is the balance between your oxygen supply and your oxygen demand. So what it's looking at is how much oxygen is left in venous blood after the body has used what it needs, okay? So when that venous blood comes back, if this SVO2 is really low, then we have a problem, okay? The person may be hemorrhaging, the person may be hypovolemic, the person may have heart failure. So this is just telling me how much oxygen is left in that venous blood, okay, after the body has used up the oxygen that it needs to survive. And remember, venous blood is deoxygenated, right? Never totally, or you wouldn't be here, correct? This part of your body would fall off. So deoxygenated. So what it's saying is I got to have some oxygen left in that venous blood. And what I should have is 60 to 80%. And if I don't have 60 to 80%, then it gives me a problem. So this is looking at more what's happening at the tissue level. So my tissues need oxygen, right? And need perfusion. So, okay, my tissues have extracted this now. The left side of the heart pumped it out to the body. All my organs and tissues took the oxygen that they needed. And then now my venous blood comes back. I want 60% minimum oxygenation in that venous blood, okay? So it's giving me a balance. So it's looking a better indication of the O2 balance or O2 supply and demand at the tissue level in the body, okay? So that's what SVO2 is measuring. That's what it is measuring. So hence, if you have a low hemoglobin, are you going to have as much oxygen? No. So if my hemoglobin's 7, and so the heart's pumping the blood to the body and my hemoglobin's 7 and my organs use up all this oxygen, I don't have as much coming back because I don't have as much in the first place, do I? If I'm hemorrhaging, am I going to have as much red blood? No. And much oxygen? No. So my SVO2 is going to be lower, okay? So you have to look at things that can affect the blood flow through the body. Well, there you go. Low cardiac output, right? If my heart's not pumping it, I don't have as much oxygen, do I? So if my cardiac output is really low, I don't have as much oxygenated blood being pumped out into the body. Hence, my SVO2 is going to be low. Because my tissues are using some of it, now it's going to be low. So it's just a way to say, hey, this body isn't getting enough oxygen, so we need to do something to improve oxygenation. That's what it's telling us, okay? And shock, again, it's because we vasodilate those blood vessels. Ventilation perfusion mismatch, basically what that means is you either have more ventilation and not enough perfusion, okay? So when you talk about ventilation perfusion mismatch, again, all you do is look at that little alveoli that I draw all the time, okay? So all you do is you look at this little alveoli, okay? This is ventilation, because what comes in the alveoli? O2, correct? And then this is in your lung, okay? So this is the venous blood coming. So it comes here, the O2 comes in, and the CO2 goes out, and this is arterial, okay? So ventilation perfusion mismatch, all right? I have a pulmonary embolism. I have a massive pulmonary embolism. This is a ventilation perfusion mismatch because what do I have more of? Ventilation. But where's my perfusion? Can't get through. Can't get through because I have a blood clot. That's all ventilation perfusion mismatch means. You're looking like, oh, I don't understand this. But if I have a blood clot, how do I perfuse that alveoli? How does the blood come to that alveoli? Because if you look at a picture of an alveoli, you got to have a blood supply. Or else how does the oxygen get from that alveoli when I breathe out into the body? Right? Make sense? So I have a blood clot. So now the blood's just hitting this, can't go forward. Can't go forward. So I still have the oxygen coming in as I'm breathing, but it's not getting perfused. That's why people die of a massive pulmonary embolism. Because it's not blocking one of these, you guys. I'm just drawing one. It's blocking a bunch of these. So then my oxygen level drops so low that I die. Because this is happening right here. I don't have enough oxygen to supply the organs. And my SVO2 is going to be way down here. Okay, so that's ventilation perfusion mismatch. Or this could be okay and the problem could be up here. Okay, so you could have the problem up here where I have a really bad pneumonia and I have all this thick stuff in here. And this could be normal, okay? And the blood's going through here. Problem is I can't get the oxygen through there. Okay? Hence, they've got to do something to increase this alveoli to get it closer to this to try to get that through. Do you understand what I'm saying? So now the problem is ventilation, not perfusion. Before the problem was perfusion, not ventilation. So pictures. Draw pictures. Remember, like I said yesterday from Dr. Albert Einstein, if you can't explain it simply to yourself, you don't understand it enough. That's what you need to go home and do with this. You're not going to understand this in one setting sitting here, okay? So that's what ventilation perfusion mismatch means, okay? So those are some of the reasons that we would have a decrease in oxygen. Okay, whoops, sorry, wrong way. Okay, there's something called the Allen's test, and you have two slides. This kind of explains it verbally, what the Allen's test is, and the second picture kind of has you do this. So what the Allen's test is it's just trying to show patency of those arteries in that wrist, is what it's trying to do. Because I have to have, they have to be patent or I can't use them, right? So basically, if you look at the next picture, so what you want to do is you want to raise the hand, okay? Like it says, raise your hand and make a fist, okay? And then you want to occlude, it's kind of hard to do with one person because you've got to occlude both your ulnar, okay, and your radial arteries, okay? And then what you want to do when you let go, you want to make sure that it blanches, and mine does, okay? So if both vessels are patent, then we can use that, okay? So don't worry about exact procedure, just understand what it's for, okay? So art lines. Your responsibility if you're in a unit with an art line is what's the blood pressure and what are my blood gases. That's what I want you to know with art lines. So see, here's a picture. So this person is occluding both the radial and ulnar artery. And then what's happening is see how the pallor, see how that's turning pale right there? And so then what happens is that when it turns pale like that, that's what they want it to do, okay? When it stays pale, that's the problem, okay? So when you let go and it stays pale, it's telling me what's not getting down here. I'm not getting a good blood supply, so I don't want to use it. Did you hurt your wrist?
No, I can't tell. I don't even notice my hand turning white when I
Oh. Well, it's hard to do it yourself. So the problem is when this pallor persists, then you can't use those arteries, okay? That's the bottom line. thing is ICG monitoring. Remember, I told you this was a non-invasive way, right, to look at the patient's hemodynamic status. Way in the beginning, I said it measures that mechanical function of the heart. So it's measuring, right, the contractility. And it's looking at the ability of that heart to deliver volume to the body. So this is what you can assess, okay? Look at all the things you can assess, okay? Quite a lot, right? Quite a lot that we just talked about. So it's performed similarly to like an EKG. They put 4 electrodes on the neck, 2 on each side, okay? So if you see, they put 4 electrodes right there. See that on the neck, 2 on each side. And then what they do is they also place some electrodes right here on the patient's chest. You see that? Okay. So look at what they're showing you this picture. These are your carotids, right? That connect here. Here's your aorta. And then those electrodes can measure what's going on in that whole piece of that circulatory system. So those, there are cables that are going to be connected to each one of those electrodes. So they have this machine, right? And then they hook a cable up to each one of those electrodes. And then what happens is those cables are hooked to this monitor that they call an ICG monitor. I don't know how they turn the dials and all that stuff, because that's somebody else's specialty. But then what it's going to do, then they have to put in the patient's height, weight, and age, okay, so that they get accurate numbers. Because remember, body surface area. So what they'll do in this machine is they'll put in the patient's height, age, and weight, and it only takes a couple of minutes. It only takes like 2 to 5 minutes to do this, and then they can figure out, you know, what those parameters are on that patient. So good non-invasive way to kind of get the same information that you would get if you used a PA line, and it's non-invasive. 2 to 5 minutes, you can get the data, right? Okay, this is the flow track that I was talking about earlier that hooks onto the art line. And so what this is going to do, this is the SpO2 right here. And it doesn't have everything on, and this is the cardiac index. So this flow track can measure different things, but I just wanted to show you this hooks right to the art line. And so this is measuring that SpO2, which is good. It's a little high, Tad, but you know, it's only 82. But so it's 60 to 80%. And then the cardiac index is what? A little bit what? A little bit low, the cardiac index. So that, I just wanted to show you. There's different kinds of machines, but Edward Life Sciences kind of have a corner on the market. So that's why I gave you that. You already know about CVPs, right, and central lines. You've already learned about those, right? So I'm not going to go through that. Okay. Questions? Questions before you take a break? Because then when you come back, we're going to work on the hemodynamic stuff.